so mundane that we just assume we know everything there is to know about it. We're talking about anemia.
It's the classic medical footnote, isn't it? You hear anemia and your brain immediately jumps to needs a nap or maybe needs a steak, and then you move on.
Exactly. It's the I'm just a little rundown diagnosis. But looking at the stack of research you've brought to the table today, specifically this really heavy-duty medical text on hematologic disorders, that casual dismissal is it's completely wrong.
It really is.
Anemia isn't just being tired. It is a complex physiological breakdown. It's like a supply chain crisis happening inside your own veins.
That is the perfect way to frame it. A logistics failure of the highest order. At its absolute core, anemia is defined as a decrease in hemoglobin, which we'll just call HB.
Yeah,
HB, or a decrease in the actual number of red blood cells. And we have to remember what hemoglobin actually is. It's the vehicle. It's the delivery truck that transports oxygen from your lungs to every single tissue in your body.
So when those numbers drop, it's not just that you're sleepy.
No, not at all. You are suffering from a decreased oxygen carrying capacity. Your tissues are literally suffocating. I mean, you could have the strongest lungs in the world breathing in pure oxygen, but if the trucks aren't there to pick it up at the dock,
And your brain, your heart, your muscles.
they're starving.
Wow. That puts a much darker spin on it than just needing an extra shot of espresso. And we actually have some hard numbers to set the baseline here, right? Because feeling low is so subjective. But the World Health Organization, they've drawn a pretty distinct line in the sand.
They have, and for a very good reason. We need a standard because so many people just drift below that line and think it's just, part of aging or stress.
So what's the line?
Okay, so the WHO defines anemia in men as having hemoglobin less than 13 grams per deciliter. For women, the cutoff is a little lower, less than 12 grams per deciliter.
And anything below that?
Anything below that, clinically, you are anemic. You are officially in a state of oxygen deficit.
So our mission today is to become detectives. Because as I was reading through this, I realized the biggest mistake people make is trying to treat anemia as if it's the disease itself. But that's like trying to treat a fever. You can take Tylenol for a fever, sure, but that doesn't fix the infection that's causing it.
Precisely. Anemia is a sign. It is a symptom. It's the smoke, not the fire. And finding that fire requires some really sophisticated detective work.
Right.
We have to distinguish between the physical size of the cells, the functional capability of the bone marrow, and navigate this really complex web of diet, inflammation, even genetic programming.
And spoiler alert for everyone listening, treating it isn't always as simple as just popping an iron supplement. In fact, as we'll see when we get to the segment on inflammation, sometimes taking iron is the absolute worst thing you can do.
That's where it gets really fascinating. The body sometimes creates anemia on purpose.
We are definitely going to unpack that paradox. But let's set the scene. We need to understand the detective work first. How do doctors even begin to classify this mess when they see a low number on a lab sheet?
Well, it starts with looking at the blood under a microscope or, analyzing the data that comes from the automated counters these days. The first major clue, the first fork in the road, is physical size.
Okay.
We call this the morphologic classification.
Has matters.
In hematology, size is everything. We look at the red blood cell and we ask three basic questions. Is it too small? Is it too big? Or is it normal-sized?
Okay, let's break those down because this seems like where the diagnosis really starts to take shape. Let's say the cell is tiny. What do we call that? Microcytic.
Microcytic, yes. So if the cell is small, it usually means the factory didn't have enough building blocks to grow it to its full size.
Not enough raw materials.
Exactly. The cell tries to divide, but it lacks the hemoglobin to fill out its structure, so it shrinks. The vast majority of the time when we see microcytic cells, it points directly to iron deficiency.
That makes sense.
Think of it like trying to build a mansion but running out of bricks halfway through. You don't leave it half built. You just decide to build a very small cottage instead.
No iron, small house. I get it. Okay, now let's swing to the other extreme. What if the cell is huge? Macrocytic.
Now that is the aha moment for a completely different set of problems. Macrocytic cells usually indicate a deficiency in either vitamin B12 or folic acid.
Okay, but why does a deficiency make them big? That seems counterintuitive.
It does.
Right.
But it's because these vitamins are crucial for DNA synthesis, specifically for the instructions that tell the cell when to divide.
So the timing is off.
The timing is completely off. The cell prepares to divide, it grows and grows, gathering materials, just waiting for the signal to split into two. But without B12 or folate, that signal gets delayed or it never comes.
So it just keeps
Huh?
swelling.
It just keeps swelling. You end up with these giant, ineffective balloons floating around in your bloodstream.
So small means lack of building materials, like iron. Big means lack of instructions, the vitamins. But then there's that confusing middle ground, normocytic. The cells are normal size. That sounds fine.
You would think so, but it's actually the trickiest category. If the cells are normal size, it means the machinery that builds the cell is working perfectly. The blueprint is correct, the building blocks are there.
But you still don't have enough of them.
Right, the quality is fine, but the quantity is low. This is usually associated with, say, recent blood loss, where you've just lost inventory but the factory itself is fine. Or, this is common, it's associated with chronic diseases where the body just decides to stop production.
The factory goes on strike.
Essentially, yes.
Okay, so that's the size classification. But the source material also talks about a functional classification. This felt a bit more like looking at the factory floor rather than just the product itself.
Exactly right. The functional classification asks why. Why is there a shortage? And we group these failures into three main categories. First, you have hypoproliferative.
Which sounds like the factory has just shut down completely.
That's effectively what it is. The bone marrow isn't producing. This could be due to direct marrow damage, maybe from radiation, chemotherapy, or a virus. Or it could be a lack of raw materials, like iron. But often it's a lack of stimulation.
Stimulation. What stimulates the bone marrow?
Well, it doesn't just work on its own. It takes orders. Specifically, it takes orders from the kidneys.
The kidneys.
Yes, the kidneys produce a hormone called erythropoietin. If you have renal disease, the kidneys stop making that call. The marrow is sitting there, ready to work, but the phone never rings.
The signal is lost. Wow, okay. What's the second functional category?
Maturation disorders. So in this case, the factory's running, the lights are on, the conveyor belts are moving, but the product coming off the line is defective.
A quality control failure.
A catastrophic quality control failure. This is where we see things like thalassemia or, again, severe nutritional deficiencies. The marrow tries to make the cells, but they're malformed. They might have misshapen membranes or unstable hemoglobin.
So what does the body do with them?
Because they're defective, the body actually destroys them before they can even get into circulation. We call that ineffective erythropoiesis.
So it's a complete waste of energy. The body is doing all this work, but getting zero results.
Exactly. And the third functional category is hemorrhage or hemolysis. This is where the factory is perfect, the product is perfect, but as soon as the cells leave the warehouse and hit the road,
They get destroyed.
they get destroyed.
Yeah.
The delivery trucks are being hijacked, or they're crashing. Hemorrhage is straightforward. You are bleeding the cells out. Hemolysis is where they are destroyed inside the blood vessels. This could be autoimmune, where your own immune system attacks the red blood cells, or it could be drug-induced. The inventory is just vanishing faster than you can replace it.
So diagnosing anemia is basically checking the inventory size, checking the factory machinery, and checking the delivery route security.
That is a perfect analogy. You have to check all three.
Let's zoom in on the one everyone thinks they know. Iron deficiency anemia. IEDA.
The most common form of anemia globally, by far.
Right. And the assumption is always, oh, I must not be eating enough spinach or red meat. But looking at the causes here, it's a bit more nuanced than just your grocery list.
It is. I mean, inadequate intake is certainly a cause, especially in restricted diets or in developing nations. But in the developed world, we also have to look very hard at inadequate absorption.
Meaning you're eating it, but it's not sticking.
Precisely. You could be eating a block of iron every day, but if you have GI issues like celiac disease or if you've had gastric bypass surgery, that iron might just pass right through you.
The body just can't grab it.
Right. Absorption is a very active process, mostly happening in a part of the gut called the duodenum. If that part of the gut is damaged or, bypassed, you're in trouble.
And then there's increased demand.
Yep. Pregnancy is the big one there.
Of course.
It's huge. The body is building an entirely new human blood supply for the fetus, plus the placenta. The demand for iron just skyrockets. If a pregnant woman isn't supplementing, she is almost guaranteed to run a deficit. She's funding two economies on one budget.
But the most direct cause mentioned in the text, and the one that seems most urgent, is blood loss.
Yes, and I really want to stress this for the listeners. In men and in postmenopausal women, we have a rule.
Okay.
If we see iron deficiency, we don't just say, eat more spinach. We assume there is bleeding somewhere until proven otherwise.
That's a stark rule.
It saves lives. Usually that means looking at the GI tract. Is there an ulcer? Is there polyp? Is there colon cancer? You cannot treat the anemia effectively without plugging the leak. If you just give iron, you're pouring water into a bucket with a hole in the bottom.
Now, this is the part of the research that really got me. The symptoms. We all know fatigue. We know pallor, looking pale. But the text lists some genuinely strange things that happen when your hemoglobin drops really low, specifically below 9 grams per deciliter.
Right, that's the threshold where the body starts to panic. It begins sacrificing the maintenance of tissues it deems non-essential just to keep the heart and brain going.
Like what?
You get something called glossal pain, a smooth, painful tongue, because the papillae, those little bumps on your tongue, they literally atrophy and disappear. You get reduced saliva.
And then there's pica.
Pica, this is fascinating. It's a compulsive eating of non-food items, clay, dirt, paper, laundry starch.
It sounds like madness, but there's a biological drive there.
It's a complete rewiring of the brain's hunger signals. The brain knows it is desperate for minerals, so it short circuits and compels you to eat earth.
But the specific one that I think is the ultimate cocktail party fact, and also a really good diagnostic clue, is pagophogia.
Pagophogia, the compulsive need to chew ice.
And we're not talking about just enjoying a cold drink on a hot day. This is different.
Oh, very different. We are talking about people who will go to a drive-thru just to buy a cup of crunchy ice. They carry it around with them. They crunch it all day long.
Why ice, though? What's the theory?
There are a few. One is that it soothes the glossal pain, that tongue inflammation we just mentioned. Another is that the shock of the cold actually triggers a small alertness response in the brain, helping to fight the crushing fatigue of the anemia.
That is such a specific clue.
It's a classic tell.
Yeah.
If you see someone who is constantly crunching on ice cups, you should just be annoyed by the sound. You should probably suggest they get their ferritin checked.
Speaking of checking, let's talk labs. Because you mentioned earlier that anemia is a supply chain issue. If I just look at my hemoglobin number, the cash in my wallet, let's say, am I getting the full story?
No. And this is where so many patients get missed in the early stages. Hemoglobin and hematocrit are actually late indicators.
Late. So I could be iron deficient but have a totally normal hemoglobin count.
Absolutely. Think of hemoglobin as the cash in your wallet. You keep that full as long as you can to pay for your daily expenses, breathing, walking, thinking. But to keep that wallet full, you are constantly withdrawing from your savings account.
And the savings account is?
Serum ferritin. Ferritin is your storage iron. It's the iron in the bank.
So the savings account drains first?
Yes.
Ferritin drops first.
That is the canary in the coal mine. Then, as the body gets more desperate, it realizes it's running low on iron, so it increases its capacity to grab any iron floating by. It builds more catcher's mitts, if you will.
So that shows up on a test?
It does. We see an increase in total iron binding capacity, or TIBC. The body is opening every door and window trying to catch a breeze.
So only after all that, so after the savings are gone and the capacity is maxed out.
Only then does the cash in the wallet, the hemoglobin, finally drop.
So if you're feeling those symptoms, the ice chewing, the fatigue, but your doctor says your blood count is normal, you should probably ask for a ferritin test.
Ideally, yes. The pattern for iron deficiency is very specific. Low ferritin, low transferrin saturation, but a high binding capacity. The body is screaming for iron.
Okay, let's pivot to the other side of the spectrum. The big cells, the vitamins, B12 and folate.
The macrocytic anemias.
I have to admit, I always just lump these two together in my head. You know, take your B complex and you're good. But the source material makes a really scary distinction between them.
It's a critical distinction. They are not the same. Both B12 and folate deficiency will cause the red blood cells to get large. Under a microscope, they can look identical. But the clinical consequences, they differ significantly.
Let's start with B12. What causes that deficiency?
It can be caused by poor diet. Vegans are at particular risk here because B12 is almost exclusively found in animal products. But more frequently, it's caused by a condition called pernicious anemia.
And what's that?
It's an autoimmune condition where your body attacks the cells in your stomach that produce something called intrinsic factor.
Intrinsic factor.
It's a protein. Think of it like a chaperone for B12. It grabs the vitamin and escorts it to the part of the intestine where it can be absorbed. Without intrinsic factor, you can eat all the steak and eggs you want. The B12 will just pass right through you.
And here's the scary part. B12 isn't just for building blood cells.
No. And this is what makes it so dangerous. B12 is absolutely essential for the nervous system. It maintains the myelin sheath, the insulation around your nerves.
So if that insulation breaks down,
The wires short out.
this is the part that genuinely freaked me out.
It should. Symptoms include numbness in the hands and feet, tingling, ataxia, which is a loss of coordination or balance, and serious psychiatric findings. Irritability, depression, severe memory impairment. It can look just like dementia.
And the text had a crucial warning here that I have to mention.
And it's so important. These neurologic effects can happen without the patient actually being anemic yet.
Wait, really?
Yes, the nerve damage can start before the blood count ever drops. And if you catch it late, that nerve damage can be irreversible.
That is terrifying. It's a silent damager. You might not look pale, you might not be exhausted yet, but your nerves are stripping.
Precisely.
Now contrast that with folate deficiency.
So folate deficiency is often due to hyperutilization, like in pregnancy or rapid growth spurts. Or it can be caused by certain drugs like methotrexate or phenytoin. It causes the exact same big red blood cells. But, and this is the key difference, it does not cause neurologic symptoms.
So your nerves are safe with folate deficiency?
Generally, yes. But here is the diagnostic trap that every single medical student learns. Let's say you have a patient who is B12 deficient, so their nerves are at risk, and you mistakenly give them folate supplements.
What happens?
Well, you might fix the anemia. Folate can actually step in and help the red blood cells divide properly so they shrink back to normal size. The blood test looks great. The doctor thinks, great, we cured it.
But you haven't touched the real problem.
You've done nothing for the B12 deficiency in the nervous system. You've masked the warning sign while the neurological destruction continues unchecked.
So you've hidden the symptom, but the damage continues.
Exactly. That is why you never just guess. You have to differentiate. You have to check the levels.
And you do that with specific blood tests for each one?
Yes. B12 levels, less than 150 picograms per milliliter, versus RBC folate, less than 150 nanograms per milliliter. You have to know which one is missing before you even think about treating.
Wow. Okay, that brings us to what I found to be the most intellectually stimulating part of this entire deep dive, the paradox. Anemia of inflammation.
This is a concept that has really evolved over the years. We used to call it anemia of chronic disease.
Right. It's associated with things like rheumatoid arthritis, lupus, tuberculosis, cancer. Basically, if your body is inflamed, you get this anemia.
Exactly. It is a hypoproliferative
Yeah.
anemia. So the factory shuts down. But the reason why it shuts down is a truly fascinating piece of evolutionary biology.
It's not an accident. The body is doing this on purpose. It's a defense mechanism, right?
Yeah. It is. Think about what bacteria and cancer cells need to grow. They replicate incredibly fast. And to do that, they have a massive appetite for iron. Iron is a primary nutrient for almost all pathogens.
So the body knows there is an invader, and it knows the invader needs iron to survive.
Right. So when the body detects a major infection or widespread inflammation, it releases these chemical signals, cytokines, that essentially say, lock down the iron.
It hides the supply.
It hides it. It pulls iron out of circulation and stuffs it into storage, into serotin. It shuts the doors to the warehouse. It actively prevents iron from being released from the gut and from the recycling centers in the spleen. It's a total lockdown.
So if you look at the labs for this, it must look totally different from iron deficiency.
Completely opposite. In iron deficiency, the warehouse is empty. You have low ferritin. In anemia of inflammation, the warehouse is full. You have normal or even high ferritin.
But the doors are locked.
The doors are locked. The TIBC, the capacity to bind iron, is decreased because the body doesn't want to bind more iron. It wants to keep it out of circulation.
That is such a crucial distinction. In IDA, you have an empty warehouse. In AI, you have a locked warehouse.
And that leads to the biggest mistake in treatment. If you see a patient with anemia of inflammation, say someone with rheumatoid arthritis, and you look at their low serum iron and you think, oh, they need iron pills, what happens?
The warehouse is locked. It's not going to get in.
Right. The iron doesn't get used, it just piles up in the gut. Or worse, you are actively feeding the bacteria or the inflammation you're trying to fight. You are giving the enemy ammunition.
So the bone marrow actually has tons of iron nearby, but it just can't access it because of this blockade.
An abundance of it. It's right there, locked away.
So treating the number, trying to force the hemoglobin up, might actually be fighting against the body's own wisdom.
Exactly. Which brings us to the complexities of treatment. Because once we know what it is, we have to fix it. And that is a minefield of its own.
Okay, let's break down treatment, starting with the basics. Treating iron deficiency.
The goal here is twofold. One, fix the anemia, yes, get the HbFs. But two, you also have to replenish the savings account. You have to refill the ferritin stores. You haven't finished treatment until the stores are back to normal.
And the text suggests a dose of about 200 milligrams of elemental iron daily, but it also calls iron diva-like. It's high maintenance.
Oh, extremely high maintenance. Iron absorption is easily blocked. If you take your iron supplement with your breakfast of eggs, toast, and coffee, you are essentially wasting your time.
Wait, really? That's a standard breakfast for millions of people.
It is. But vegetables, grains, dairy, eggs, they all contain compounds like phytates and phosphates that inhibit iron absorption. And tea and coffee contain tannins, which are potent blockers. They literally bind to the iron in your stomach and prevent it from ever entering the bloodstream.
So when is the best time to take it?
Ideally, 1 hour before meals, on an empty stomach. An acidic environment helps absorption, so taking it with vitamin C, maybe a small glass of orange juice, is great. The acid helps the iron dissolve and absorb.
But there's a catch, isn't there?
There is. Iron on an empty stomach acts like a corrosive. It can be brutal on the gut. Nausea, pain, constipation, cramping. So often, patients end up taking it with food just to tolerate it, even though we know it absorbs worse. It's a trade-off.
And what about the type of iron? I see different names on the bottles at the pharmacy. Ferrous sulfate, gluconate, fumarate. Does it matter?
Ferrous sulfate is the standard. It's cheap and it's effective. But I do want to warn your listeners about pills labeled enteric-coated or slow release.
Why? That sounds fancy and good, like it would be easier on the stomach.
It sounds good for the stomach, and it is, because it prevents the iron from releasing until it's further down the intestine. But remember, iron is absorbed in a very specific window, the duodenum, right at the start of the small intestine.
So the slow release misses the window.
It can bypass that window entirely. It releases the iron too far down the track, and you absorb nothing. You're essentially just swallowing a pill and pooping out a pill.
So avoid the fancy coatings. Stick to standard ferrous sulfate, empty stomach if you can handle it.
That's the gold standard.
Now, what if pills don't work? Or the person has malabsorption or simply can't handle the stomach pain? Then we go to the IV lines. Parenteral iron.
Right. We bypass the gut entirely. We have great options now like iron sucrose or sodium ferric gluconate, but we have to talk about an older one, iron dextrin.
The texts mention a black box warning for that one.
It does. Iron dextrin carries a significant risk of anaphylactic reactions, severe allergic shock that can be fatal. It requires a test dose where we give a tiny amount and wait for an hour just to see if the patient reacts.
That sounds intense just to get some iron.
It is. The newer formulations like iron sucrose have much lower risks, but they aren't risk-free. We still have to monitor for hypotension, a drop in blood pressure, and cramps. It's a serious medical procedure, not just a top-up.
Let's jump back to B12 treatment for a second. You mentioned something earlier that I want to clarify. You said oral B12 works even for people with pernicious anemia, the people who lack the intrinsic factor to absorb it. How is that possible if they lack the chaperone protein?
This is one of those medical dogmas that has really changed in the last decade or so. We used to think if you lacked intrinsic factor, you had to have injections for life. Period.
Not anymore.
Not anymore. We've discovered an alternate absorption pathway, a backdoor, essentially.
Backdoor. I like that.
Exactly. If you flood the system with high enough doses of oral B12, we're talking 1 to 2 milligrams daily, which is massive compared to the daily requirement. About 1% of it gets absorbed passively. It just diffuses across the gut wall without needing intrinsic factor at all.
That is wildly convenient.
It saves patients from a lifetime of monthly injections. However, there is a caveat. If the neurologic symptoms are severe, if they already have numbness or memory loss, we usually start with injections anyway.
Why?
To get the levels up fast. Because remember, nerve damage is time sensitive. Time is tissue. We don't want to wait for that slow passive diffusion to kick in while the nerves are still being damaged.
Right. Now, the most controversial treatment area, treating anemia of inflammation, the locked warehouse.
This is very tricky. As we said, iron usually doesn't work because the warehouse is locked. So medicine developed these drugs called ESA's erythropoiesis-stimulating agents. Drugs like epoetin alpha.
These are basically synthetic versions of the hormone that the kidneys make to tell the bone marrow make more blood.
Correct. It's the accelerator pedal for the factory. And for a while, they were used quite liberally in cancer patients and renal patients. But then the data came out.
The dangers listed here are stark.
They are. We found that if you drive the hemoglobin up too fast, more than 1 gram in 2 weeks, or if you drive it too high, specifically above 12 grams per deciliter, you significantly increase the risk of mortality and cardiovascular events.
Wait, so making the blood too normal can actually kill the patient?
In the context of chronic inflammation in these drugs, yes. It seems that pushing the system that hard creates thick, sludgy blood, high blood pressure, and clots. heart attacks, strokes.
So what's the goal now?
The goal isn't to get them back to normal. The goal is just to keep them out of the danger zone where they might need a transfusion. We tolerate a lower hemoglobin level to avoid the risks of the drug.
That's a sobering balance. Just keep the patient functional, don't chase the perfect number.
Exactly. And transfusions are the last resort. We only transfuse if the hemoglobin is critically low, usually between 8 and 10, and they are symptomatic. Blood transfusions carry their own risks of reactions and iron overload, so we don't do it lightly.
Before we wrap up, we have to touch on the vulnerable populations mentioned in the text, the elderly and pediatrics.
Yes, the elderly are particularly fragile in this regard because of something called marrow reserve.
The factory's getting old.
The machinery is rusty, yeah.
Yeah.
As we age, our bone marrow just loses its cellularity, its bounce-back ability. So a minor nutritional issue or a minor bleed that a 20-year-old would shrug off can drive an 80-year-old into deep anemia.
So you have to be more aggressive in looking for a cause.
Much more aggressive. You can't just chalk it up to getting old.
And for kids.
Prematurity is a huge risk factor. Babies get a massive iron transfer from their mom in the last trimester of pregnancy. If they were born early, they miss that deposit. They literally start life with an empty bank account.
And then they hit those growth spurts.
Right. The factory can't keep up with the expansion of the building. Rapid growth increases the demand for iron massively. That's why we have specific dosing for infants' iron sulfate drops to bridge that gap until they're eating iron-rich solid foods.
So we've covered a massive amount of ground today. From the size of the cells, micro, macro, normo, to the locked warehouses of inflammation. If we had to boil this all down for the listener, what are the big takeaways?
First, anemia is a symptom, not a disease. Always, always ask why. Don't settle for, I'm just low on iron.
Find the fire.
Find the fire. Second, ferritin is your best friend. It tells you the state of the savings account before the crash happens.
And the distinction between the empty warehouse of iron deficiency and the locked warehouse of inflammation.
That is crucial. Do not throw iron at a locked warehouse. And finally, take B12 deficiency seriously. The nerve damage is real, it is silent, and it plays for keeps.
I think my biggest takeaway is that final provocative thought we touched on, the wisdom of the body. We spend so much time trying to fix our numbers to match a textbook, but in the case of anemia of inflammation, the body is deliberately suppressing iron to starve an infection, to protect itself.
It raises the question, right? When should we intervene, and when should we respect the biological strategy? Modern medicine is powerful, but millions of years of evolution usually have a pretty good reason for what they do. Sometimes the body lowers the blood count to save the life.
Next time you get a blood test, I guarantee you're going to look at those numbers differently. You're not just looking at a list, you're looking at a supply chain, a factory, and a defense strategy all in one.
It's a fascinating story written in red.
Thanks for diving in with us. We'll see you on the next one.
Take care.